joining us. All right, well, welcome everyone. It's so great to see each of you. Today is our first day of the Introduction to Palliative Care in refugee camps in Kenya. And we are really excited that you are with us today. You have been chosen by your employer, which is the Kenya Red Cross of Kenya. Kenya Red Cross, as well as International Rescue Committee and MSF, Médecins Sans Frontières, who are joining together with us for this course. And I'll just share my screen so you can learn a little bit more about the way we are going to be running the program. So my name is Erin. I'm a palliative care nurse from Canada, and I currently live in Nairobi, Kenya. Most of you would have met me online previously as we started getting the course organized, and I hope to get to know you each more as we go along. Each class of our courses will be approximately 1 hour. Today might go a little bit longer because we are going to be teaching you about how the course is set up and hoping that we can iron out any issues. But we're really grateful that you are here with us. Along with the implementing partners of this program, we have a partnership with several other organizations that are supporting the training that we are going to be doing. So originally we had shared that it was a 6-week training, but we are grateful because we have a speaker that's going to join us, and he is a physician that works very close to you, and he'll be doing the 7th week. So in terms of the partners for this course, we're grateful that KEPCA, which is our Kenya Hospice Palliative Care Association in Kenya, along with the Africa Palliative Care Association, which is called APCA, and PallCHASE, which is the global network supporting palliative care integration into humanitarian settings. And we have another partner, Two Worlds Cancer Collaboration. They're a foundation that is out of Canada supporting improved access to palliative care and cancer care around the world. And we're really honored for this program to be a Project ECHO course. So welcome so much. And again, my name is Erin. We have a great number of faculty on this course, and I just wanted to introduce them. Some of them are on the call with us today. And I'd love if you could unmute and maybe put your video on. We'll start with Dr. Ali. Oh, Dr. Zippy's on the phone. Dr. Megan, do you want to say hello?
Hello and welcome to everyone. So nice to be with you. I'm Dr. Megan Doherty. I'm a palliative care pediatric physician in South Asia. I lived in Bangladesh before. Nice to meet you all, and I'm really excited to be with you for this course.
Thanks, Dr. Megan. A few others I see. Vilma, would you like to introduce yourself and say hi?
Hi, everyone. I'm Vilma Oliveros, and I am currently in Canada working for a community hospice, and I'm looking forward to meeting you all.
Thank you. Thanks so much. Vilma is one of our new faculty members. Really excited to hear from her and her teaching. Dr. Zippy, do you want to say hi?
Sorry, hi. I didn't realize I was still on video and I was on the phone.
No problem.
Hi, everyone. The phone call just came in and I was, yeah. But hi, everyone. Just happy to meet everybody on this call today, and hopefully looking forward to an exciting time throughout the entire course. Thank you.
Great. And I see Sarah is with us. Sarah is one of our new faculty as well. Do you want to introduce yourself, Sarah?
Hi, my name is Sarah. I'm a registered nurse also from Canada and currently living in Nairobi. And I'm really excited to participate in this course, and I hope we can learn a lot together.
Thanks so much, Sarah. So we have a few other faculty members that weren't able to join today, but I'll just introduce them. We have Professor Julia Downing. She's a palliative care nurse and the executive or the CEO of the International Children's Palliative Care Network. And we have Dr. Omar Abdi Hamid, who is a clinical oncologist based in Garissa. and he'll be helping us out. Dr. Marianne Phillips is a pediatric and adolescent oncologist from Australia, and she also specializes in palliative care. You might know Annalise and Ali Hamid. They're both clinicians that are working currently in the Dadaab refugee camp. So you might know them. Annalise is a palliative care nurse working with the International Rescue Committee, and Ali Hamid is a clinical officer who recently had been also working with IRC. Then we have Dr. Kayla Wolofsky. She is a palliative care clinician from Canada, and we're really looking forward to her teaching during this session. We also have Dr. Nicola Ayers. She's a nurse that's working in Ethiopia, originally from the UK, so she'll be supporting the work. Yodang Nkolata is one of our PallCHASE members, and we're really looking forward to her supporting as well. Doris is our last faculty member, and she is from Ghana, and she is a oncology nurse, and we're really excited. We're a large team, and we do hope that we'll be able to work well together and to support you during this time. So just a recap, there's going to be 7 sessions, and each session is mandatory. Each week, we'll be sharing a short video that you can watch before class, and then we'll have a summary of the teaching during the session. At the second half of the hour call, we will have a clinical case presentation, and then depending on your attendance for those sessions, we would love to be able to give you a completion certificate at the end of that. We also will have an option for people that are not able to attend the live calls. They can listen to a recording afterwards and then finish a short quiz. But we do recommend, as much as you're able to attend the live classes. So what is Project ECHO? Project ECHO is a model of teaching that we are going to be using. And what we've now established is a hub. So we, through APCA, the Africa Palliative Care Association, and PallCHASE, are going to be our hub. We're the expert team. And you, in each of your facilities, are becoming a spoke. So you are the individuals that are participating in the training. And we hope that through this training and health teaching, that you will be able to impart the knowledge that you gain from it towards your colleagues, your patients, and even community health workers. So as you attend the sessions, we will be working with you and engaging with you over the next several weeks. And we're hoping that you'll then be able to pass that information and the knowledge across to those that you interact with on a daily basis. So in the past, Two Worlds Cancer Collaboration and PallCHASE have been doing these ECHO projects. We've just completed 2 programs in East Africa, one in May 2022 and one in February 2023. But Two Worlds Cancer Collaboration, which is the organization that Megan was representing as well, has been doing training since 2020 in the response to the Rohingya refugee crisis in Bangladesh. So they've actually run nearly 7 batches of that program, and there's several other ECHO programs and training courses they've run in that region as well. I did mention the other partners. We wanted to highlight Africa Palliative Care Association. They are one of our main partners and are helping us run this program. Their main aim and objective is information, integration, and evidence. And you can read this at a later time, but there's some elements to the work that they want to bring to ensure that palliative care can be for all people in Africa. PallCHASE is our other organization that is supporting this training session, and it is a network of professionals focused on advocating for palliative care and end-of-life needs for people that have been affected by disasters or humanitarian crises. So just so you know, and you're aware of those that are engaging in this project. So I do want to remind you that ECHO is a little bit different than telemedicine. So if we look at the ECHO model that I just described to you about the hub and the spoke, we have an expert hub team. So those are us here as the faculty that I just introduced you to. Each of you represent the red individuals here as the learners who are supported through your community, your organization. So that is the Kenya Red Cross, That's IRC and MSF. And then the knowledge that you gain from the course over the next several weeks will then allow you to hopefully begin to implement the things that you have learned and begin to change the way you provide care to your patients. In a traditional telemedicine model, a specialist or an expert would actually take over and manage the care directly of the patient. And that's not what we're trying to do here today and through the rest of this course. It's not a traditional telemedicine program. You as the treating physician, you retain all responsibility for managing your patient. You'll bring cases or examples or questions to the group, but you will be the one who will be ultimately still providing the direct care. It isn't all teach, all learn. So we want this to be a really supportive community. We all can learn lessons, lessons can be shared, questions are really encouraged, and we really focus on times of discussion. This is what a general session will look like. We'll have our short introduction or welcome, and then there'll be some summary teaching. So today that teaching will be done by Dr. Zipporah Ali. Then we will allow for some time of discussion and questions. So you can add your perspective, you can ask questions in the chat, or even unmute during this time. After that, we'll have a case presentation. And for our program at the moment, this will be done by one of our faculty members. And in the future, we really look forward to you as individuals presenting cases. We'll then have time for discussion. Sorry, it should have been to 3:45 until 3:55 for questions for about 10 minutes, and then we'll just do a final summary and have any remarks. A reminder for when we're on Zoom, just to try to keep your video on if your network allows, and do keep yourself muted just to avoid any background noise. Please do relabel yourself on your device so it doesn't come up as iPad or iPhone or whatever type of device you're using. We do really strongly encourage you to put any questions or comments in the chat, and whoever is facilitating the call will allow you to unmute or engage in discussion as necessary or as able. So you'll see that we recently have been enrolling in our iEcho website. And this is a really important tool that we hope that you will use over the course of this time. So you'll see your sessions will come up. I've been able to input all of the sessions. It will show you there the time. Today I made a bit of a mistake because we still had it at 4 to 5. But actually all of our sessions will be running from 3 to 4. And you'll see either through the direct email reminder that you get, you can join our link, or you can go on the website directly. We will be sharing a Google Drive where we have some PDF documents of palliative care content that is shared with all of our participants and all of the different echoes that we've been running in East Africa. So you'll also have access to that as well. So you can go through that slowly if you want to access some more resources. And we do have a YouTube playlist. So this is a playlist of some basic teachings for palliative care. Some of them will send you the links ahead of time, but if there's a topic that you're interested in looking at, you're more than welcome to review those. And I can share these links after I finish this presentation. I think most of you are on our WhatsApp chat, but here is the link to the WhatsApp chat. And again, I'll put this in the Zoom chat. It's an important way for us to communicate and engage with each other. And if you have any questions, you can email us. So the email is PC for palliative care, humanitarian echo@gmail.com. And that email is checked fairly regularly, and we try to get back to you as quickly as possible. So that's it for our basic introduction of what the course is going to look like. I am going to ask for all the individuals that have been joining, please do introduce yourself in the chat. We had a few minutes at the very beginning of the call for people to say hello, but we're now going to move on to our teaching session. So just in the chat, if you are able to put your name and the organization you work for, that would be great. And I think actually for our faculty, if you're able to do that as well, I know some people joined a little bit later. I'm sure they would love to get to know you. So I will now introduce our faculty member for today that will be speaking on introduction to palliative care in humanitarian settings. Her name is Dr. Zipporah Ali, and she has been working in Kenya tirelessly for many, many years promoting palliative care. She is now retired, but she has been the executive director of the Kenya Hospices and Palliative Care Association for nearly 17 years, if I'm not mistaken. And she's recently taken on a role as a chair of the NCB Alliance in Kenya. So she's not relaxing at the coast during her retirement. And we are very grateful because she often comes on to our calls and our teachings and is very enthusiastic. She's very connected. So if you ever need someone to advocate for you, please do get her contact details. But I'll pass it over to you, Dr. Zippy. And if anyone does have any questions while we're going, please just put them in the chat. Thanks, everyone.
Okay, thank you very much, Erin, for that elaborate introduction. And I just want to also thank everybody who is in this session today, the students particularly, for your actually eagerness to understand what palliative care is, especially in places where you're working, where it can be quite difficult. So we'll really be looking at what palliative care is today. And I don't know if any of you attended the sessions we had recently, the webinars we had recently, where Dr. Megan and Dr. Catherine spoke on palliative care. They were really elaborate on what palliative care is. And I think one of the key things that came out, of course, for most people attending, is that palliative care is for everyone. Everyone who is breathing and still alive and is in need of palliative care should have access to it. So what we are trying to do is also to ensure that this project that Erin and other colleagues have started is that people who are living in situations which are beyond their control, that are very difficult, also have access to quality palliative care throughout the continuum of their illness. So we'll be focusing on what the things that we need to do in terms of people accessing palliative care. And I'll be talking about what palliative care is. I think most of you probably know what it is. You have an idea of what it is. You probably maybe have gone through some sessions, because I noticed that we have people from IRS, and we've done some training with the group from IRS. I've noticed there's some people from MSF also in the training. And I know MSF is actually working on a project right now in London. I was in communication with them to set up start palliative care in the MSF project, because I think Dr. Catherine tried at one time, and so they think they need to build up on what has happened before to ensure that people have got access to palliative care wherever they may be living. So we'll be talking about what palliative care is, and like I said, it is for everyone. We are a small group, so if you feel that maybe you need to stop me in the middle and ask a question, please feel free to put your hand up, and we'll be able to respond to your question as we continue with the sessions. Now, I just put a few definitions of what palliative care is on my slides. If you look at the International Association for Hospice and Palliative Care, IHPCA, in case you don't know who they are, find time to Google them and find time to join the association as a member, because it has a lot of journals that you can access, and a lot of information that can actually help you, even in developing palliative care where you're working. It has also guidance on how to start up a palliative care service where you're working. So please look them up and join them. But IHPCA says palliative care is care of patients with aggressive, progressive, advanced diseases or a short life expectancy, for whom the focus of care is the relief and prevention of suffering and the quality of life. So you'll notice there are a few words that actually, some words that are very, keep on coming up in every definition you have of palliative care. Quality of life is the prevention of suffering. It's about advanced illnesses. And its focus is not usually on just patients only, but also focuses on the family of the patient and whoever it is that is involved in the patient's care and around the patient. So if you look at the WHO definition, it's maybe a little bit more comprehensive and says that it's an approach that seeks to improve the quality of life of patients and their families facing problems associated with life-threatening illnesses through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. It actually goes on to say it also includes care for family members and loved ones after the patient has passed on. That is bereavement care. And again, you're realizing it's about quality of life. Whatever we're doing in palliative care is really focusing on improving the quality of life of the patient. It doesn't matter if they have a few days, even a few hours left. we must make sure that they have good quality of life. They're not in pain and suffering. We are addressing the physical, psychological, emotional, and spiritual needs as they need them. So it really is focusing on quality of life of the patient and the family. And again, one of the things we need to remember that it's not really waiting until a symptom or something has happened. It also looks at how can we prevent certain things in a patient's journey. If you're expecting they're going to be vomiting because we prescribe morphine for them, how do we ensure that they will not vomit? How do we, tease out things like normal bereavement within a family member and handle those things? So it focuses also on preventive services. So the key the WHO key facts about palliative care, and also I'll also encourage you to read the Global Atlas of Palliative Care 2020. I think the latest 2020. It's available also online, especially if you are able to Google World Hospice and Palliative Care Alliance, you'll find the Global Atlas there. It actually talks about palliative care globally, where the gaps are, where the needs are, and it's a good document to actually familiarize yourself with. We know there are about 40 million people in need of palliative care. About 80% of these people live in countries like Kenya. So we have a big need of palliative care in our countries. And only 14% of these people who need palliative care are able to receive it. Now, we don't even know what percent really are able to receive within our own countries. In Kenya, in fact, our palliative care strategy says only 1% of the people who need palliative care are receiving it, which is unfortunate because we do have palliative care services almost in every county in this country, but access to most of them is still a problem. Of course, it talks about adequate national policies, programs, and resources, and training on palliative care. That we need to improve training on palliative care for healthcare professionals, community health volunteers. But apart just from improving training of those who provide services, we also need to do a lot of advocacy for those who need these services. Most people don't come for palliative care or hospice care because they think when they come there, it means people have given up on them, we have given up on them. So we need to demystify those thoughts. So we encourage patients to receive these services when they need them. So palliative care is really a big problem globally. Even where it's easily available, they still have challenges in many ways. So we are facing challenges as a global village in terms of people accessing quality palliative care. But of course, this does not mean that nothing can change. We can actually change this, and that's why we are here today to ensure that we actually bring about change where we are. So palliative care will focus a lot on pain management, and I think Erin will be sharing with you the program, or I shared with you the program that the topics we'll be going through. They might not all be there, but mostly we focus a lot on pain management. The reason why we pick out pain management separately from the other symptoms is a lot of times pain is not well treated in our countries. We don't assess pain, we don't classify pain, we don't have the medications for treating pain adequately. Most institutions don't actually have opioids for pain management. We know that opioids are very effective in pain management, especially in cancer pain and other pains, and they're also relatively safe to use and easy to use. So again, that's why we really kind of focus on pain management separately, pain management for children, for adults, and even for the elderly. Other distressing symptoms can also be treated in terms of, there are many, if you look at a cancer, the symptoms that actually for the cancer patient experience, there are almost like 65 different types of symptoms you can talk about. So we need to be also to look at how can we address these symptoms. Other issues that we usually talk about is breaking bad news, telling the patient and the family that maybe the disease is not going to be cured, and so talking about the prognosis. Those are things that are usually very difficult, especially in our cultures, to talk about, to almost talk about the fact that this is not going to be cured. But there are ways we do this so that we don't kill anybody's hope, we foster hope meanwhile. So of course, other topics could be ethical and legal and professional issues. And then advanced care planning, end of life care is very important. When a patient is dying, how do we support this patient? What are our goals of care at that point of time? How do we support the family? How do we support ourselves also as caregivers? Because also we go through a lot as caregivers. Of course, we talk about spiritual, emotional support, psychosocial support, bereavement support, and of course, care of the carers, the families, the healthcare workers. And of course, don't forget research. Without research, we'll probably not be doing what we're supposed to be doing, because evidence, especially local evidence, to improve quality of care, value-based care, and all those things needs a lot of research, whether it's clinical research, whether it's whatever research you're doing. Sometimes even we might have to do research on patients, but this is because that research is going to improve the care we give to our patients. So those are some of the things that we talk about in palliative care. It is an essential area of healthcare that focuses on relieving and preventing suffering of patients with incurable diseases. A recent study, not recent, really, it's about 5-6 years publication by Lancet, actually talks about has been trying to redefine palliative care. It's about health-related suffering and not necessarily just using words like terminal, life-limiting, or life-threatening, but looking at health-related suffering holistically in terms of how can we define palliative care. This is a conversation that's going on between WHO and experts if they should redefine it, but at the end of the day, it's really about quality of life. And if you look at the Sustainable Goal developments, you will actually look at goal number 3, which talks about good health and well-being, and we are part of that. Good health and well-being means that even if a patient has a life-threatening illness, they should live a decent life. They should live in dignity without pain and suffering, and if they're dying, they should not die with pain and suffering. So we are also part of the development goals. So we need to focus on them as well. Who can provide palliative care? We all can provide palliative care. Sometimes people think, oh, you have to have a palliative care specialist. I'll give you an example. In this country, most of the providers in palliative care are actually nurses. Nurses provide most of the palliative care in this country. They're the ones who are working in hospices, they're the ones who are working in the palliative care units. Of course, it's good to have also specialist doctors, because sometimes you might need a referral to a higher level when you find that maybe there are certain things that you're able to handle. But anybody who has some basic training can provide palliative care. And that's why, for example, in Kenya, we are focused a lot on including palliative care into the core curriculum of training for nurses, for doctors, for clinical officers, for pharmacists, and other healthcare professionals, because we think and believe that a person has to really graduate understanding the basic principles of palliative care so they can provide these services to a patient whenever the patients need them. So we might not have specialists, medical doctors, but a lot of times we try to have as many nurses involved in terms of supporting patients. So palliative care can be provided by anybody who is a healthcare professional, has received some training, and of course has empathy towards patients, because you can receive training, but if you're not empathetic and willing, then you might not even be the best provider. And if you look at human rights talk about rights to health. This has been on for a long time. Usually the general right to health will talk about right to health from promotive, preventive, curative, rehabilitative, reproductive health, and most recently, for example, in Kenya, we have added palliative care, and now we're adding mental health. So if you look at human rights, it talks about rights to health for everybody. We don't discriminate against anybody. It doesn't matter which part of the world you're living in, what conditions you're living in, whether you're male or female, what religion, what color, whether you're disabled or not. It doesn't really matter. It's what matters is that you're a human being, and you should have access to healthcare, because it's a human right. And so even if you look at the issues of refugees, where most of you are working, there is a right also for refugees to have access to health. And mostly, it's the country that is hosting refugees is actually supposed to take up this right and work on it. It's supposed to, because they receive money. Like Kenya, we have refugee camps. They receive money from donors who are supporting them to take care of refugees, not just housing and food, but also take care of their health. So even human rights applies. All human rights in terms of health also apply to people who are living in these tough situations and conditions. They have a right to access healthcare that is good healthcare, including palliative care and end-of-life care. So it is not discriminative. It talks about health, access to health for these people as well. So it's needed in humanitarian crisis, and I think it's needed even in those situations more than it is anywhere else, because sometimes patients in such situations might have a diagnosis of an early diagnosis of cancer or at whatever stage it is, but that's where the story ends mostly. They are not able to go and get treatment because they don't have a health insurance where they're living. They don't have access to specialist treatment centers. So all they can receive at that point of time is palliative care, which is unfortunate, because if you have a diagnosis of an early cancer or any other disease and are able to access treatment and get cured, that's what should actually happen. That really is the thing that should happen, but sometimes it doesn't happen. And so most people who are living in these situations will need access to palliative care. Although our advocacy should focus on treating what you can treat. If you're able to treat that cancer or whatever illness the patient has, if you're able to get them to the next level of care, that's what we should really be able to do. But sometimes the conditions are so tough that we are not able to move these patients from one point to another point. Whichever way, I think it's important that we focus on the fact that we have palliative care services where we're working, and patients should be able to receive these services in whatever setup they are in. So humanitarian conditions are very important. They're very sensitive. The people usually are in such desperate situations there. And so it's important that we also integrate palliative care services in the services we provide in these places. So I won't go into the history of palliative care really into deep, but palliative care has been there for many years. The first hospice, the first modern hospice was started in 1967 by Dame Cicely Saunders. And over time, it spread many other parts of the world. In Africa, we had Zimbabwe as the first place to have a hospice, followed by South Africa, then followed by Kenya and Swaziland, and many other countries came up. But most of these services were very limited to a few people because it was usually a hospice in one place or two places. With time, for example, in Kenya, the last 15 years or so, we've tried to ensure that palliative care is not just being provided by hospices, but it has also been integrated into a healthcare system, especially in the public and mission hospitals, that people can receive palliative care in those hospitals close to their home, where it's actually easier for them to access these services. So there has been a lot of improvement in terms of palliative care in Africa, but we still need to do a lot. As much as we have some of these services, many patients don't come to them because they think they think that people have given up on me and they send me to these centers. So there are many barriers to palliative care, just what some of them I've just mentioned. For example, patients and families not understanding what it is, doctors also and other clinicians not understanding what it is. Funding is a big problem as well. Most of our countries do not put a separate or do not put a specific funding for palliative care or for access to opioids. That's also another problem. And that's why it's important to have it fully integrated. Then, of course, it's budgeted for just like any other healthcare services. So there are many other challenges that we can talk about. Challenges to accessing opioids is a big problem. Most countries do not stock opioids, do not have opioids because of the many regulations around opioids, the punitive laws around opioids, which we need to really address because we are denying people access to pain simply because we are not able to put controls within our country so that we are controlling the illicit part of it, but ensuring that we have access to opioids for medical and scientific purposes. So that is also another challenge that has happened, but a lot of awareness, advocacy, and influencing our governments and our governments and any other stakeholders involved in healthcare is very important for us to be able to change the situation. So again, you might actually face barriers where you're working, and maybe when we end the session, you might be able to share some of those barriers in your place of work, and we can see how we can address those barriers. You probably have even more different barriers than the normal healthcare facilities. Am I too fast? So in humanitarian situations, I think the most important thing usually is saving lives. For those of you who work in humanitarian situations, you know that usually a lot of focus is given on saving lives, and that's very right. Where we can save our life, we should actually save our life. We should never let a life go because we're not able to do something about them. But sometimes we are not able to save lives, or even as we are trying to save those lives, the person is going through a lot of pain, whether it's physical, emotional, or through some very devastating symptoms. We should also be able to focus on those issues for the patient. Even as we're trying to save the life, we should focus on the needs of the patient. Sometimes patients come to the hospital, they're in so much pain, and as clinicians, we focus on the disease, on the cancer, for example, and forget that this cancer is creating pain, is making this patient vomit, is putting a lot of pressure in whatever the patient's where it is, and we forget to address those symptoms and just focus on we need to give chemo, we need to give radio, but we're not addressing the things that probably made the patient come to the hospital. They didn't know they had a tumor in the abdomen. They came because they were in pain, or that the abdomen was distended. So we need to focus also on relieving the patient's suffering symptoms. But saving lives is, of course, very important. So that means that we need to strike a balance between these two and not just focus on one. So for palliative care to have a humanitarian response, the challenges need to be addressed. And this is actually from a study that I read that helped me prepare this presentation. I just thought because it has been done by people working in those conditions. It says the ethos of humanitarian action is that true humanitarian goals include life-saving, elevation of suffering, and promotion of dignity. Again, we talked about dignity. Dignity is very important. As somebody is going through an illness, even if they're dying, they should be everything should be dignified for that patient. So although life saving is the overriding commitment that animates humanitarian healthcare, we need to also focus on alleviating the suffering of the patients. When lives cannot be saved, this reality may therefore be experienced as a failure of humanitarian actors, but that's not true. Even as doctors, I know we are trained to heal, to cure, but most of our patients, or a number, or maybe not most, but quite a number of our patients might not be healed, might not be cured. And that should not make us feel that we have failed. Certain things are beyond our control, but we should do as much as possible to ensure that this patient has a good quality of life. So again, continuing with this is, again, it talks about making space for palliative care in humanitarian action, reflections on obstacles, the integration of palliative care approaches in humanitarian healthcare. So this has focused on the ethos of humanitarian action, the need to optimize resources in humanitarian settings, the need to appeal to donors, lack of training and expertise in this area, and barriers to accessing pain medications. So these are some of the challenges that were found in this study, looking at humanitarian conditions. So how can we address some of these challenges? And then maybe you can tell us also if these challenges are some of the challenges you're facing in your place of work. How do you plan to address these challenges as we continue with this course? Because at the end of this course, we are hoping that you'll be able to integrate palliative care services, you'll be able to come up with a plan of action that we can help you actualize and implement in your place of work. So let's be thinking about what are the barriers in our place of work. Others are concerned that this care could be provided by local actors, lack of organizational policies and sector-wide standards. Do we have policies in our place of work? Do we have standards for palliative care? And of course, there are issues like respiratory risks, terminology, and other things. Even when you're talking about terminology, how do we describe palliative care to the people you're dealing with? If you're going to a refugee camp, for example, people are from different backgrounds, from different religions, from different languages. What common language can we use that people can understand, or do we focus on each of the different tribes and people so that they can have a better understanding of what it is that you're talking about? So there are many challenges that are brought up in this particular study. So the major challenge is still to make healthcare professionals understand why palliative care is important. Unless you who are in this session today understand that it's important, you'll not be able to influence change. You'll not be able to influence the place of work. You'll not be able to have palliative care integrated. And also the other challenge that is also has been brought out is the use of morphine. It's still a very big controversial issue among healthcare professionals. And this, I'm telling you, is true. I have doctors who see patients and they don't prescribe morphine. They say that wait until the patient is dying. And so the patient is in pain until maybe a day or so before they die. And then it's too much for the patient and the family. The memories of the family members for this patient, the pain and the crying of this patient remains forever. So we need to change our attitude. We need to be educated, understand how to use opioids for our patients. And of course, health systems need to fully integrate palliative care for it to be sustainable. There are many recommendations that were given by this particular study. It says overcoming each of these obstacles will require different forms of action, both within and beyond humanitarian organizations. So we need to work with the humanitarian organizations as well to be able to support them overcome these challenges. Again, responding to them is very vital. So I think our donors, the big bodies, the big money people, and everybody else, human rights organizations, everybody needs to be involved to be able to respond to this situation. So so that people are able to access good quality palliative care, and if they're dying, they should die without pain and suffering. So again, these are just things that are brought up in this study that we need to focus on in terms of supporting our patients. In Kenya, we have done some bit of work with the refugee camps. I think the first training we did was in 2008 or 9 when we trained in the Dadaab camp, but I don't know if that was really, we didn't follow up, unfortunately, which is really not good. We followed up for some time, but what happened is that the people we trained would move on to another place. They were temporary. So we actually eventually didn't follow up very well. But in 2018, I think we went back again to the lab and Kakuma through IRC and trained again. And so I hope that the people we trained are still active and implementing palliative care services. But again, apart from training, I think the advocacy at the leadership level is very important. If the leadership in that institution does not support the people who want to provide these services does not ensure that there is access to the medicines for palliative care that are needed or other commodities, then it will be very difficult to really sustain palliative care services. So it is very important that whatever we are doing, even in these sessions that we are doing here, Erin and team, that we'll be able to follow up with the trainees to help them with the challenges so that they are able to provide palliative care and ensure that they have also trained others. Even if they were to go, there's somebody else who can continue these services even if they are not there. So just to think about any of the challenges that we have in our place of work, I'm sure we have issues with healthcare services. Do we have enough people? Where are we located? And what kind of challenges do we have? So again, that might help us throughout the session to understand how we can support the trainees. So again, of course, sometimes what I've noticed with for example, the camps for refugees is that people go there for a short time, mostly on locum. They go there for 3 months, make some good money, and move on because of the conditions that they might be working under. But let's also think of the conditions of the people who live there, and yet they have to live there because they have no other place to go to. So if they can live there, and why can we not also be able to ensure that we are providing care throughout, and not just working away with the knowledge and not training others? So let's look at also sustainability issues. How do we sustain these services to continue once we start them? So there are many resources that can help you in terms of understanding more about palliative care. I'll put some of them on the slides here, and I know Erin is going to share these slides with you, so you can look up these resources. They are free online. You can get them online. They're free. But even WHO has resources that helps. UNHCR has resources that help. So look up those resources and see how they can support you in your place of work. Attend as many sessions as you can in terms of education. I know these are old posters, but even last week, I can't remember, it was last week or 2 weeks ago, we had very, very interactive sessions, very beautiful sessions. Try to make sure that you're attending as many sessions as you can so that you can keep your knowledge up to date and you're involved and you feel you're part of the community. And I think Erin will be talking to you about PallCHASE and the rest, how you can join. So that's also some of the things we need to look at. I won't go into that, but we want to say thank you very much for so many people who actually support palliative care. So these are some of the organizations in Africa, palliative care associations or organizations that are ensuring that palliative care is fully implemented or integrated into their healthcare systems in their own countries. So again, if you want to reach out to see APCA is there, KEPCA is there, ICPCN, if you want to reach out to some of these organizations in your country, please feel free to do so, because I'm sure they will be very happy to work with you, whether it's to give technical support or even to help get some funding to be able to implement palliative care services. So in summary, palliative care is a holistic care. It's a holistic approach. It looks at the patient holistically and also at the family. It's for all age groups, and it includes rehabilitation and optimization of function. So we want to make sure our patients have a good quality of life. We usually say the Nairobi Hospice put life into their days and not just days into their lives. So whichever number of days they are, we would like to see those patients as active as possible and living a good quality of life. Thank you very much. I don't know if there are any questions, but yeah, thank you. That's all I had to talk about today.
Thank you so much, Dr. Zippy. We don't have a case today, but I think we now can spend the rest of the time engaging in a discussion. And I'm quite curious, because some of you we don't actually know very well. Dr. Zippy is always on different calls, but I'm sure many of you are new to her and to myself. What are some of the challenges that you all face? Dr. Zippy shared quite a lot, explained about what palliative care is, but also some of the challenges of working in a humanitarian setting. If you can share in one sentence what one of the main challenges that you are facing right now, maybe this will help start a discussion and we can just understand a little bit more about where you're working and what you're facing. You can put it in the chat, or if you feel comfortable, you can raise your hand. It's under the reactions. There's an option to raise your hand, and then I can unmute you, or if you want to unmute. Okay, funding, interesting. So funding for palliative care work or funding for medical treatment in general? Eva, do you want to, or both? Nice, all of the above. All right, anyone else? Teresa, would you like to share something? Yes, this is a big one. Dr. Zippy, if you have time, do
Hello.
I'm sorry. Want to comment on the lack of diagnostic tools or assessment tools? I don't know if you talked about that when you did your in-person training.
Okay. I think first, okay, this is a very wide question. Thank you for it. Most times, by the time the patients we are taking care of come to us, they already have a diagnosis wherever they're coming from, or whoever has seen the primary doctor or whoever has seen the patient has already made a diagnosis. In palliative care, we usually have we do have a lot of tools. For example, tools to assess pain, tools to assess spiritual distress and others. And so these tools help us understand, for example, how severe a symptom is so that we can treat it. I don't know if those are the tools you're talking about, but diagnosis is a big challenge. I assume in the places where you work, if somebody comes with a tumor, maybe if it's an obvious breast, enlarged breast, maybe, or you can maybe think this is probably breast cancer, but then you need to confirm, because for cancer, we usually want a confirmation, a biopsy, that so that even the ones who are going to treat this patient can actually plan how to treat the patient, because they have to stage the cancer and all those things. I know that I can't tell what diagnostic equipment you have in your place of work, but usually I know that most times, if it's possible, you refer the patient to the next level of care, where they can maybe get the diagnosis. But mostly we don't keep diagnostic equipment in our places in palliative care, because by the time that patient comes to us, we assume they already have a diagnosis, and now ours is to support the patient throughout the journey of the disease, whether they are undergoing curative treatment or whether they are just receiving palliative care. So I think what you need to do is find out in your place of work if you have a facility or equipment or even whatever you need in terms of reagents and all those things, even if you have specialists, because to make a diagnosis of cancer, for example, you need a pathologist or a histologist. Do you have those people in your place of work? So it might be very difficult for you to make a proper diagnosis where you're working, because you don't have the human resource needed, you don't have the equipment needed, and so you don't have the other facilities that are needed. And that's when you now maybe think, shall we refer these patients to a higher level where they can make a diagnosis? So otherwise, in our palliative care units, in our setups, we don't really do a lot of diagnosis, because by that time, like I said, the patient comes with a diagnosis. In terms of funding, I'll just respond to that also. Funding is a problem for everybody. I think what is important for me, what I found to be sustainable, is ensuring that the service you're providing is part of the healthcare services provided in the institution. So it's embedded into that healthcare, the healthcare services that you have. If you have, for example, antenatal services, you have maybe you have services for NCDs. Why don't you also have services for palliative care integrated into your healthcare system so that they're sustainable? And if you also, sometimes we do have what we call small grants that are usually go out there, call for small grants. We'll go out through African Palliative Care Session where you can apply for grants. Mostly they're grants to help either with setting up training or, some of the fee challenges. They're not humongous grants, but they can help you. Hospice Care Kenya also, these are people who are interested to support, these are organizations who are interested to support palliative care even in humanitarian conditions. So you need to be on the lookout when this call for grants comes so that you can apply. And this is only if you become a member, if you become a member of the African Palliative Care Association or a member of Kenya Hospital Palliative Care Association, because they send out emails to members to say there's a grant call that has come up. But it's good also just to partner up, so to be looking out for grants, and also particularly looking out for grants that support palliative care in humanitarian conditions. I know MSF has a very big project called the transformational in whatever capacity, it's a TIC project that is now going to be supporting palliative care in MSF, and they have a lot of money, but none of us really has applied for those kind of funds. So we need to be on the alert, look out who can support what we are doing and apply for funds. But like I said, sustainability lies within your healthcare system, that you integrate these services so they're sustainable. The human resource comes from the people working with you. The medicines are also budgeted for in your institution. Thank you.
Thanks, Dr. Zippy. Some things have come in on the chat. Some of the other challenges people are mentioning about movement of patients. Oftentimes when they suspect a cancer, they request for referral and it's often denied. I just put in the chat the contact details of Dr. Omar. He's one of our new faculty members, and I'm really hoping will be a good connection for each of you within your organizations. I'm not sure if any of you know him, but he is the new clinical oncologist consultant that is based in Garissa, which is your closest cancer facility. And he is quite eager. He wasn't able to make the call today, but he's quite eager to be finding ways to support you when you have patients that you're concerned or you're thinking may have a suspected case of cancer. So please write his information down. It will be good. I think next week he will be on the call. You will get to meet him. And we'll start working together to find good ways to connect you with him, whether that's on a weekly update call aside from this training, or whether that's through WhatsApp or whatever seems to work best. He seems to be quite keen, possibly of starting even some clinical rounds to talk about your patients on a regular basis. So that I think is a really huge plus for the program and this training that we're doing, because I really understand the challenge and the barrier when you are not able to provide care, you're not able to diagnose, and referrals are not really an option for many people. I'm going to bring a few of our faculty into the call. Sarah, are you with us? Sarah?
Hi, Erin. Yeah,
Hey.
I'm here.
Hey, there was one challenge that someone put on the chat with the high staff turnover. So I know, Sarah, you used to manage a hospice in Canada. How would you guys work with your colleagues when there seemed to be a high staff turnover? So you've trained someone and then 3 months later they leave, or 6 months later they leave. What did you guys do in more of like a management side of things?
That's a really tough one because there's so much, there's a lot of resources and energy that goes into training people, especially when it comes to a specialized area of care like palliative care. We were fortunate to not have huge issues with turnover. And so we didn't face that kind of in and out cycle of having to retrain nurses and healthcare providers on a regular basis. I think one of the things that really helps with keeping services streamlined is to have materials available for new staff that they can review, that they can learn while they're on the job. And so even if someone is coming in new, there is sort of like a resource manual to access that gives you information, tools, all of the sort of like policies that maybe you're using available in one place that can be easily understood, accessed, and then implemented. That would be my sort of feedback on that.
Yeah, almost part of an orientation, including palliative care training as basic orientation. At the moment, does anybody receive palliative care training or talk about palliative care during their orientation? Maybe you can just put that into the chat. Vilma, are you still with us? I know it's the morning in Canada.
I am here. I was actually just writing that I do have to go because we're already late for school, but
Oh, nice.
yes, but I do have a lot of resources that I can share in regards to like whatever they need to know.
Oh, nice.
Community.
Yeah, I
So
was wondering because I know you're part of the home hospice in Canada. What do you guys do when you come across a patient or a family that doesn't have a lot of money to pay for the very high-end diapers or wound care? What do you guys usually recommend? Are there some things that you can recommend to families that make paying for some of these supplies a bit easier?
That is a very hard question, actually, because the funding that they get from we don't do anything with funding. Most of our services are volunteer based.
Yeah.
So we advocate like trying to find sometimes donations, but if it's if they have access, well, they do have access to home and community care, then they could provide something. But yeah, I hear a lot of complaints about that too here, because people don't have the resources to buy a lot of stuff. So it's a complicated one, but I can find out more and see.
Yeah, even just I know we try to do as much as we can in terms of reusable items, but it can be difficult when we come across someone with a a large wound. It's hard if you have to be buying supplies every single week. But yeah, if you come across anything, we'd appreciate it.
Yeah, okay. I'll keep that in mind. Okay, I do have to go, so bye everybody. This is great.
See
I'll see
you.
you next week.
Bye, Vilma. Thanks for being with us. Okay, we're coming up to the end of our session. Does anyone have any other final questions or comments?
Erin, I just wanted to clarify, Ahmed made a comment saying that we are guided by UNHCR referral guidelines, which limits the referral of patients with a terminal illness within the camps. I just wanted to ask maybe Ahmed if you could clarify what that means.
Yes, hello, how are you all?
Hi, Ahmed.
Yes, there is, I usually work with MSF, the palliative care program. And yes, we have a referral guideline by UNHCR, which guide us which kind of patients we can refer. I think you can share a request, Dr. Sophia, to share with you.
Yeah.
And there are vast number of conditions which we cannot refer from within the camps, especially the cancer cases, even if it's an early stage cancer. Initially, we used to benefit from what we call the reverse referral, specialists coming to the camps. But again, due to security issues and other complicated issues, we are not receiving any specialists coming to the camps. So most of our cases are just clinical confirmation, and some of the patients are requesting to get diagnosis of their conditions and for them to be referred, but we can't refer because of that referral guideline.
I think from my understanding is that any patient that the clinician in the camp believes may have a terminal illness, they're not able to get access to UNHCR funding for the referral. So there's several diagnoses and probably like descriptions or demographics of the patient that would qualify for a referral out of the camp. So they would either go to Nairobi or they would go to Eldoret and they would get care. Once the care is finished, then they would come back to the camp. But what my understanding is any person that seems to have progressive disease doesn't matter. Yeah, and the thing is, it's also very difficult for people to diagnose in the camps. So people don't get a diagnosis and they're kind of waiting around, and then the symptoms become quite high. So anyone with a serious chronic non-communicable disease, including advanced cancer, really aren't able to access any treatment. So I think it is a huge gap that palliative care can provide. It's not the solution I think that we want, because I think better referral systems are a better option for the refugees that are there. But in the meantime, while the systems are more of all the systems, while we try to change the systems, we need to know what to do. And I think that's why this course is actually going to be really, really important. Of course, the work that KEPCA has done over the years in the camp is really important, but I think ongoing regular support and training for palliative care is really important. I looked, you guys all filled out a survey recently that I had shared, and most of the participants in the course are seeing up to 10 patients that are requiring palliative care, like on a regular basis. So the numbers are quite high. I think many of the patients, Ahmed, that you see that are not able to be cured or you cannot access curative treatment would benefit and do require palliative care. Do you agree, Ahmed?
Yes, sure.
Yeah. All right, well, we're done for our session today on that note, on that heavy note of talking about all the challenges. I do hope that you guys will be able to join us on a weekly basis. We'll have all of our calls at this time from 3 to 4 on Thursdays. I think there's one holiday in June that we'll miss class for, but we're quite excited. We're quite eager to have this training. Each week we'll have a short session topic and then we'll talk about a patient. Yeah, thank you for your engagement. There is a feedback form that I put in the, there's a feedback form that I put in the chat. So if you're able to click on that, then that also will help us as we try to make the program better. So thanks so much. If you have any questions, Ali, did you want to say hi to everyone? I know you didn't get a chance earlier. Sorry. Ali Hamis is one of our faculty members. You might know him.
Hi, Erin.
Hi,
Good
Ali.
afternoon, my colleagues and the rest of my participants today. I don't have much to say here. Let me welcome all participants in the forum, and we'll be happy next session next week, inshallah. Say hi, my colleagues.
Thank you, Ali. And Annalise, are you also still with us? I think you joined a little bit after, but we had a chance to introduce all the faculty. Annalise, do you want to say hi? Maybe her connection is not quite great.
Erin, I did
Oh.
it on the,
Oh, you did it on the chat.
yes.
Nice. Thank you. Annalise is one of our committed faculty members as well. She's been working with the International Rescue Committee in Dadaab for 10 years as a nurse, and she's the focal point, I think, for palliative care on her team. So thank you for being with us. And Tanis, I don't think you had a chance to introduce yourself with Tanis. You can go ahead.
Hi, my name's Tanis. I'm a intern with PallCHASE, and I'm just finishing up my master's in global health at McMaster University in Ontario, Canada. And it's nice to meet you all.
All right, well, thank you, everyone. Thanks for staying on for a few extra minutes. If you have any questions, you can reach us on the group WhatsApp chat, or you can email me. So please don't hesitate. I'm really looking forward to a few weeks. Thanks, everyone.
Thank you. Bye.
Bye.